Assalamualaikum. Pulmonary function tests are as Assalamualaikum. Pulmonary function tests are as Assalamualaikum. Pulmonary function tests are as spirometry. Today I am presenting the lecture, which is the part of a chapter of a respiratory system for a first year Doctor of Veterinary Medicine students. So, as you are knowing that we are conducting all these lectures online. So, the pulmonary function test or spirometry, the spirometry meaning the measuring of breath, is the most common test for a pulmonary function test, measuring the lung function, specifically the amount, the volume, the speed of the air that can be inhaled or exhaled. What's spirometry? Spirometry is a method of assessing the lung function by measuring the volume of air of the patient can expel from the lungs after a maximal expiration. So, what are the types of spirometers which can be used for a spirometry? The bellows spirometers measure the volume mainly in the lung function units. Then the electronic DAX type top spirometers that measures the flow and the volume with a real-time display, and the small handheld spirometers, inexpensive and quick to use, but having no print on it. So spirogram cannot be developed in a printing form. So this is very easy to use. Why we perform the spirometry? Measure the airflow obstruction to help make a definitive diagnosis of the COPD. Uh, that they confirm the presence of airway obstruction, assess the severity of airflow obstruction, and monitor the disease of a progression in a COPD. They detect the airflow obstruction in a smokers who may have a few or no symptoms. Assess the fitness in the drivers. The persons are alcoholic or they are not able to be fit as a driver, that can be assessed by a spirometry. Assess the prognosis by the first expiry volume in 1 second in COPD diseases, to conduct the pre-operative risk measurement before anesthesia or the cardiovascular surgical or cardiothoracic surgeries, in which the open thoracic surgery can be performed. Why we perform a spirometry? The spirometry is indicated for the following reasons: to diagnose or manage asthma, to detect the respiratory disease in patients presenting with the symptoms of breathlessness, and to distinguish the respiratory from a cardiac diseases as the cause, to diagnose and differentiate between the obstructive lung disease and restrictive lung disease, to follow the natural history of a disease in a respiratory condition, to assess of an impairment from occupational asthma, to identify those at a risk from the pulmonary barotrauma while scuba diving, to measure the response to treatment of a conditions which is due to a spirometer or due to any disease. The hemolysis of an unknown origin is contraindicated. Don't use the spirometry in a hemolysis in a pneumothorax or angina pectoris or myocardial infection, thoracic aneurysm, abdominal aneurysm, cerebral aneurysm, recent eye surgery due to the intraocular pressure during a forced expiratory, the recent abdominal or thoracic surgical procedures, the patients with a history of a syncope associated with a forced exhalation. Patients with active tuberculosis should not be tested with the spirometry. We can measure 4 lung volumes and 4 lung capacities by the use of a spirometry. A lung capacity consists of a 2 or more lung volumes. The lung volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. And there are 4 lung capacities. One is the total lung capacity, inspiratory capacity, functional residual capacity, and the vital capacity. The tidal volume means it is the volume of air moved into or out of the lungs during a quiet breathing. That might be a 500 ml. Inspiratory reserve volume, it is the maximum volume that can be inhaled from the end inspiratory level after the inspiration of a normal tidal volume. The more can be inspired, that is 3100 ml. If the tidal volume is a 500 ml, so you can even more inspire in the lungs, that might be 3100 ml in a capacity. Expiry reserve volume means it is the maximum volume of air that can be exhaled from the end of expiry position after the expiration of a normal tidal volume. That tidal volume can be expired up to 500 ml, but you can even expire a more volume, that is about 1200 ml, if you by a pressure, by a force, if you are expiring the reserved volume which is reserved in the body. Residual volume is, it is the volume of a air remaining in lungs after a maximal expiration, that is also a 1200 ml. Total lung capacity, it is the volume of the lung at the maximum inflation or a maximal amount of air that can be fill the lungs, that is a 6000 ml. So the total lung capacity is equal to a tidal volume plus uh, inspired reserve volume plus expired reserve volume and reserve volume. So this is the total capacity of the lungs, whereas the vital capacity, it is 4800 ml, which may be the 80% of the total lung capacity. So the vital capacity is equal to a total volume plus inspired reserve volume plus expired reserve volume. So this is known as a vital capacity. So it is approximately about 80% of the total lung capacity. The volumes varies according to age and body size. Inspired capacity, it is the maximum amount of air that can be inspired, that is the 3600 ml. The inspired capacity is equal to the tidal volume plus inspired reserve volume, whereas the functional residual capacity, it is the amount of air remaining in the lungs after the normal expiration. So the volume is a 2400 ml. The functional residual capacity is equal to a reserve volume plus the expired reserve volume. Now you can see the lung volume in a milliliters, that is about inspired reserve volume up to 6000 ml, whereas the uh, tidal volume is about 5000 ml, whereas the residual volume is about 4800 ml. The expired reserve volume, the vital capacity, the inspired capacity, the functional residual capacity, and as well as a total lung capacity, which is about 6000 ml, and the functional uh, residual capacity is about 2500 ml or 2800 ml, whereas the inspired capacity is about the 3800 ml. So you can see that the spiro that can be varied with the age, and the lung capacity can be varied with the age and the sex. The spirometry test is performed using the device is called a spirometer, which comes in several different varieties. Most spirometers display the following graphs called spirograms: a volume time curve showing the volume liters along with the y-axis, and the time in seconds along with the x-axis. So the a flow volume loop, which graphically depict the rate of the air flow on the y-axis, and the total volume inspired or expired on the x-axis. The most common parameters measured in spirometer is the vital capacity, forced vital capacity, forced expired volume that can be calculated on a 0.5%, 0.5 seconds, 1 second, 2 seconds, 3 seconds. Forced expired flow can be measured in a 25%, 50%, up to 75%. The maximum value volumetry ventilation is also known as a maximum breathing capacity. The functional residual capacity cannot be measured via the spirometry, but it can be measured with a plethysmograph or dilution test. Forced vital capacity. Forced vital capacity is the volume of air that can be forcibly be flown be blown out after the full inspiration, measured in liters. The forced vital capacity is the most basic maneuver in a spirometer test. Forced expired volume in a 1 second, that is the forced expired volume in a 1 second is the volume of air that can be forcefully blown out in 1 second and after a full inspiration. Average values of a forced expiry volume 1 in the healthy people depends mainly on sex and age. So the value between the 80% to 120% of the average value are considered normal. The forced expiry volume in 1 second divided by the forced vital capacity, that ratio is being presented in a percentage. So that is about 75% to 80% in the adult healthy and human being. Forced expiry flow, that is the forced expiry flow is the flow or a speed of air coming out of the lungs during the middle portion of the expiry. Post expiration, it can be given at a discrete times generally defined by the what fractions remains of the forced vital capacity. The usual intervals are 25%, 50%, 75%. The breathe is until the lungs are full, hold the breathe or seal the lips tightly around a clean mouthpiece and apply the nose clip not to breathe from the nose. Block the air out as forcefully and as fast as possible. Provide the laughs of encouragement. Continue blowing until the lung feels empty. Wet the patients during the blow to ensure lips are sealed around the mouthpiece. Check to determine if an adequate phrase has been achieved. Repeat the procedure at least twice or more until ideally the three uh, range average within the 100 ml or 5% of the each other are optimal. Spirograms patterns are normal, obstructive, restrictive, and mis-obstructive and restrictive. So the spirograms curves may show the in a healthy patient 80, more than 80%, the forced vital capacity, then the forced expired volume in 1 second is 80%, and the total fraction is 0.7%. So the air obstruction having the forced volume capacity low or normal, where the forced expiry volume low and forced expiry volume in 1 second divided by forced vital capacity is low. Restrictive having the follicular forced volume capacity and low or a normal forced expiry volume in a 1 second, where the forced expiry volume in 1 second divided by forced vital capacity percentage, that's the in a airway obstruction it's a low, whereas in a airway restriction it is 0.7, means normal or increased. Mixed having a low forced vital capacity, whereas the forced expiry volume in a 1 second is also low, ratio is also low. So this is the graph of a normal press having the forced expiry volume in 1 second 4 liters, forced volume capacity 5 liters, the ratio is 0.8%. In obstructive disease, it's 1.8 liters and the forced volume capacity is 3.2%, 2 liters, and the ratio is 0.56. The forced expiry volume 1 is 1.9%, forced volume capacity 2 liters, and the ratio is 0.95%. The forced expiry volume 1 in 1 second is 0.5 liters, forced volume capacity 1.5 liters, the ratio is 0.3 liter. All these parameters are lower than normal. Spirometry, the common problems in ADCAT are incomplete below, lack of a blast efforts during an inhalation, slow start to a maximal effort, lips are not sealed around the mouthpiece, coughing during the below, extra breath during the below, glotting closure or obstruction of the mouthpiece by a tongue or a teeth, poor posture and leaning forward. Thank you very much. Okay, this is closed over here.